Good evening all. Welcome to ISA online PG classes. Today we have amongst us a very enthusiastic, very lively and excellent teacher, Dr. Ranju Singh from Lady Hardinge Medical College, Delhi. And she will be speaking on a very, very important topic, which is very important in our day-to-day clinical practice, whether they are postgraduates or young consultants, equally important for all of us on supraglottic airway devices. Welcome, Dr. Ranju Singh.
Thank you so much, Dr. Naveen, for that wonderful introduction. And it's lovely to be here amongst all of you. And thank you for this chance of giving me a chance to do what I love to do the most, teach the students. So thank you so much.
Thank you. So I request Dr. Nishant, the coordinator, along with Dr. Monica Chikara, the second coordinator, to please carry on the proceedings. Over to both of you.
Right. Thank you so much, sir. And yes, we have been witness to many of our ma'am's lectures also. She is actually a brilliant teacher, which I'm sure all the postgraduate students will benefit. Ma'am, these are the ISA online classes that are held every Monday from 5 p.m. And this is the 44th in the series. And reputed teachers like you yourself spare the valuable time to teach the students, and it is of immense value. For the course of the session, ma'am, everybody will be muted. And just in case there are any questions that the audience might have, they can type it in the chat box.
Right.
And if there are any questions that you might have, all the audience members are encouraged to write the answers in the chat box itself. We'll discuss it as we go.
Right.
So that is the plan of action, ma'am. And I'd request Dr. Monica to please formally introduce everyone to Ranju, ma'am.
Thank you so much, Nishant.
Good evening, everyone. So ma'am needs no formal introduction, but still, ma'am is a director professor in Lady Hardinge Medical College and associated hospitals, and she has a special interest in pediatric anesthesia, obs anesthesia, and life support. She has established the Delhi chapter of Indian Association of Pediatric Anesthesiologists, and currently is the president there. And she's a vice president in Delhi chapter of ISA, instructor in AHA accredited courses like ACLS and BLS. And she's a senior faculty in Airway Management Foundation. She's an instructor in National Teachers Training Program. And she's trained in acupuncture. She has been examiner in MD, DNB, and DA, and is assessor with NMC. She has more than 200 presentations and more than 60 publications, including chapter and books in national and international journals. Ma'am, we are very glad to have you here and listen to your lecture. Over to you, ma'am.
Thank you so much, Dr. Monica. I will be sharing my screen now. During the course of the session, there will be MCQs which are.
And madam, you can unmute yourself.
Now, thank you, Monica. During the course of the session, there will be certain questions for the interest of the students and the listeners. And as the question comes on screen, I'll take a small breather while I let Nishant handle the question and the answer. And hopefully we'll have an interesting session. And let me begin by sharing my slides. Visible?
Yes, ma'am.
And audible?
Yes, audible, ma'am.
Okay. Thank you very much. Thank you. I begin the evening with a very warm welcome to everybody who's listening in, including the students, co-faculty members, and a lot of my esteemed teachers whom I could see on the screen. Thank you to ISA and a very, very happy Buddh Purnima to all of you. सबको आज के शुभ दिन की शुभकामनाएं. It's a very auspicious day to teach and learn about a very, very important topic for us as anesthesiologists, the supraglottic airway devices. I have tailored the session for postgraduate students, trying to answer through the talk many questions which they are likely to face in a viva. So before we start, Nishant, can you start with this first question for all the PGs, please?
Yes, ma'am. So the first question to begin the session is, uh, when inserted into a patient, where is the laryngeal mask airway usually situated in relation to the vocal cords? Is it superior? Is it inferior? Is it posterior? Or is it lateral to the vocal cord? So all the listeners are encouraged to type their answers in the chat box. And we have a first answer by Dr. Neena.
Which is?
Superior, which is A, and most of them have answered. Dr. Neena, Dr. Archana, Dr. Neha, and I think everybody is A, superior.
Fantastic. So actually this question is here because this is the basis for the definition of supraglottic devices. Now, the supraglottic devices are airways that are intended to open, secure, and seal the supraglottic area to provide an unobstructed airway in a spontaneously breathing or mechanically ventilated patient, typically during the anesthetic procedure. There are various terminologies which are used. Many of them will be called supraglottic airway devices or supraglottic devices, abbreviated either as SADs or SAGs. And many a times, extraglottic airway devices is also probably a term which refers to supraglottic devices. So across the world, many times different terminologies are used for these devices in literature. Now, over a period of time, airway management, which is such an important part of our job as an anesthesiologist, has seen a lot of developments in equipment. It was a breakthrough in 1981 when Dr. Archie Crane invented and developed the ClassicLMA. It turned airway management on its head around 180 degrees. We had a new device which provided us an alternative to the traditional endotracheal tube for airway management. And it is quoted in literature that Dr. Archie Crane used the prototype on more than 7,000 subjects before the first commercial devices were launched in 1988. Another decade later was another path-breaking invention, which was of the intubating LMA. In 2001, we had the ProSeed, and subsequently, the market has been flooded with a large variety of supraglottic devices with newer innovations in material, in the construction, and in the way the device works. 2007 saw the launch of the very popular Igel, and the pediatric sizes of the Igel were launched in 2009. At present, there are 30 such devices used for, meant for use as supraglottic devices currently present in the market. Now, why this need for the supraglottic device was felt? Endotracheal intubation is paramount to us as an anesthesiologist. It's what we've learned through the ages, and it's an extremely important part of our job to control the airway. But putting an endotracheal tube requires rigid laryngoscopy, and rigid laryngoscopy is not without its own set of problems. It produces a huge hemodynamic response, what is classically known as the pressure response to laryngoscopy and intubation, associated with a jump in the blood pressure and the pulse rate. It can provide damage to the oropharyngeal structures. And of course, some amount of morbidity to the airway does occur, which can be of serious concern. So there was always a need for a simple and effective alternative to endotracheal intubation, which was provided by the supraglottic devices. These supraglottic devices avoided traditional rigid laryngoscopy. That means it provided a less invasive means of securing the airway. They were very easy to place, much faster. It could be placed in the neutral position, unlike the endotracheal tube, which always requires a sniffing position to be put. A higher success rate was seen even with inexperienced personnel. Now, endotracheal tube requires a lot of experience and requires a lot of practice. But supraglottic devices have a short learning curve. They can be easily put after minimal training. They were much better tolerated by patients. The use of neuromuscular blocking agents was not mandatory with the use of supraglottic devices. And we've talked about the hemodynamic response that was caused by laryngoscopy and intubation. This hemodynamic response is substantially reduced with the use of supraglottic devices. In addition, it, unlike laryngoscopy, produces minimal rise in intraocular pressure and intracranial pressure during insertion. The supraglottic devices classically have been classified depending upon the presence of the following characteristics: whether there is the presence of an inflatable cuff in the device or not, what is the location of the distal end in relation to the glottis, whether it protects against aspiration or not, and what is the sealing mechanism of the device. Now, they have been very commonly classified into first generation or second generation devices. First generation supraglottic devices are those which are simple airway tubes that do not have any specific design characteristic aimed at reducing the risk of pulmonary aspiration of gastric contents. The second generation devices, on the other hand, incorporate specific features to improve the delivery of positive pressure ventilation and significantly reduce the risk of aspiration. ClassicLMA, Igel, Ambu Oracane, LMA Supreme are some examples of second generation supraglottic devices. Another classification is present of an inflatable cuff or not. The cuffed supraglottic devices and non-cuffed devices have been separated out. The non-cuffed devices include devices such as Igel and Baska. The remaining devices, most of them have a cuff and are known as cuffed supraglottic devices. Location of the distal end of the tube in relation to the glottis is also a basis for their classification into supraglottic and retroglottic devices. Supraglottic devices like the ClassicLMA or the ClassicLMA or the family of Ambu masks provide a seal around the glottic inlet and remain superior to the larynx. The retroglottic devices, on the other hand, terminate in the upper esophagus and remain posterior to the glottis. The sealing mechanism is also a basis for their classification into cuffed pharyngeal sealers, which can either be with an esophageal seal or without an esophageal seal, and cuffed perilaryngeal sealers, which can have non-directional sealing like the LMA or a directional sealing. Now let us have a brief look at the clinical indications of the supraglottic devices. As I've already mentioned, it has now become an alternative to traditional endotracheal intubation, even for routine delivery of anesthesia in patients who have normal airways. This is a paradigm shift in the airway management from the endotracheal tube era. Initially, the devices were put for patients who were spontaneously breathing, but increasingly with the launch of more sophisticated and safer devices, they are now easily used for patients who are paralyzed with muscle relaxants under anesthesia. A wide variety of surgeries and different groups of patients, such as children or obese patients, now are managed with the use of a supraglottic device. Nishant, a question for the PGs now.
Yes, ma'am. So, use of a supraglottic device would be most appropriate for airway management in which of the following patients? We don't have options, ma'am?
Yes.
Yeah, okay. So, A, obese patient with acute appendicitis who after rapid sequence induction cannot be intubated, or B, an elderly patient with severe restrictive lung disease scheduled for inguinal hernia repair, C, an obese male patient with hiatal hernia and gastroesophageal reflux disease scheduled for umbilical hernia repair, or D, a full-term parturient brought to the OR from the labor room for emergent cesarean section for fetal bradycardia. So, use of supraglottic device would be most appropriate in which of the following patients? And we have a lot of responses, ma'am. And mostly it is A, obese patient. Dr. Manasa was the first to respond. Dr. Akanksha, Dr. Varun Preet, they've all answered A.
Okay. Okay. We will come to these indications and contraindications as we move along the talk. We leave it in suspended animation till then.
Right.
Now, the other important part of use of supraglottic devices, besides the section of elective patients or elective surgeries or normal airways, is those in difficult airway. They have a very, very established role now in patients who have a difficult airway. As we are all aware, a difficult airway means dividing the part which is difficult. You can categorize whether the patient will have difficult bag mask ventilation, difficult laryngoscopy, or a difficult intubation, whether the invasive airway in that patient will be difficult, or whether that patient will have a difficult emergence or an extubation. Now, at many places along this, the supraglottic devices have a role. They can be used as a primary airway device. It can be used as a rescue device, and it also can be used as an aid to tracheal intubation. Now, this is the algorithm put forward by the ASA. This is the 2022 edition. And I suggest that the postgraduates must go through this article, the most recent article regarding the ASA difficult airway algorithm. And in very beautifully in this algorithm, the use of supraglottic airway devices has been defined. Supraglottic devices can be used as a substitute for a face mask. What we've essentially done with the use of supraglottic devices is we've shifted the face mask from the face of the patient and we've converted it into a mask sitting on top of the larynx. So all the conditions where face mask ventilation is difficult, this could include edentulous patients, patients with large and heavy beards, those patients who have facial growths, tumors, hemangiomas, etc. Look at this picture on the right side of the screen. The patient has a large growth on the lip. Now, mask ventilation will be very difficult in this patient, but if you can circumvent this problem, probably the rest of the airway management will be uneventful. So conditions like this, where mask ventilation is difficult, the supraglottic devices has a huge role to play. It can be used as a substitute for the mask and can be used as a primary device for oxygenation, which means that after induction of anesthesia in this child, instead of attempting oxygenation through a face mask, you can directly put a supraglottic device and continue oxygenation for that patient. It frees the hands of the anesthesia giver. Sometimes the supraglottic device can be used in patients who have reduced mouth opening. We'll also come to this in a little while later. It's a beautiful intubation guide. Not only does it provide access to the airway by itself, but many places where laryngoscopy or intubation has failed, we can use it as a conduit for guided intubation. Now, this intubation may be blind or it may be fibroscope guided. It is recommended that the intubation be fibroscope guided as far as possible, because use of a fibroscope highly increases the success rate of a successful intubation. And intubation through these devices, when placed in a difficult airway scenario, have really increased the success rate of accessing the airway without significant morbidity to the patient. Now, Nishant, the question, students next.
Yes, ma'am. So, tracheal intubation aid. So, which of these devices do not aid in intubation? Is it the Igel, the LMA Supreme, the Ambu Aura Gain, or the Airq?
Which devices do not aid intubation?
Yes. So, there is a response, ma'am. It is a mixed B and A response.
Okay.
Dr. Mansa was the first to respond, I think. Yeah.
Dr. Mansa seems to be an extremely active student. She's answering all the questions.
Yes, yes. No, the response is very brisk, ma'am. A lot of responses are there.
Okay. So some of them have answered A and some of them have
answered B. Yes. So it's a mixed A and B response. Igel and LMA Supreme.
Okay. We'll also come to this. We'll leave the questions in suspended animation and keep answering them as we go along. And when we focus on the probably the next slide or subsequently, we get to answer which of these devices do not aid intubation. So this is the list of devices which do aid intubation. Igel, the Ambu Aura Gain, Ambu Aura I, the Airq laryngeal airway, the LMA Fast Track, the LMA Protector, and the Blockbuster LMA. What is not there in the list is the LMA Supreme. So the answer to this question is B. Why this happens is when we come to discussing LMA Supreme, we'll see why LMA Supreme is not a good device for intubation. Now, as I've mentioned again, it is recommended in literature that fiber optic bronchoscope be used to guide the intubation through the SAD. This is because it allows a better visualization of the glottic structures when you use a fiber optic bronchoscope. It extends the apnea time and instrumentation is minimized. Intubation through the supraglottic device, besides being aided by a fibroscope, can also be aided by the use of other aids. A gum elastic bougie can be inserted through the SAD as a first step, and this can be followed by advancing the endotracheal tube over the bougie. The entree catheter may also be used to guide the endotracheal tube through the supraglottic device. The supraglottic device is then removed while keeping the catheter in place, and then the endotracheal tube can be advanced or railroaded over the catheter into the trachea. Another three-step technique which has been described in literature, although it is not very commonly used and not very widely recommended, is the use of a guide wire. Occasionally, when the glottic opening is very narrow and it allows only a guide wire to be inserted, that can be done through the fibroscope. Then the removal of the SAD can take place, and an intubating catheter can then be railroaded over the guide wire, and finally, the endotracheal tube can be railroaded over the catheter. Another important indication in today's scene is use of supraglottic devices for resuscitation and pre-hospital airway management. Tracheal intubation is extremely difficult in emergent situations. As it is, it requires a lot of skill, it requires positioning, it requires somebody to help you with the steps. And in conditions where there is resuscitation going on, where the stress may be very high, where the position of the patient may not be optimal, the laryngoscope may not be in the best of conditions. In those conditions, the failure rate of endotracheal intubation can be relatively high. But more important than this, during periods of chest compression, if you need to access and establish a definitive airway with an endotracheal tube, it requires cessation of chest compressions. And once the chest compressions have ceased, it is very difficult again to get the flow up. So it is recommended that the chest compressions be carried on without interruptions. And while the chest compressions are going on, a supraglottic device is used for establishing a definitive airway. It is easy to insert, extremely quick, not much training is required. With minimal training, paramedics can successfully insert a supraglottic device in field conditions. Besides this, less extension of the cervical spine is required for insertion of the supraglottic device as compared to direct laryngoscopy. This is very important in the field situations where trauma patients may also be encountered. So in all these conditions today, supraglottic devices has almost certainly replaced, even in the guidelines, as a device for the control of the airway during cardiopulmonary resuscitation. The supraglottic device can also be used as an extubation aid, which means that this device can be used alongside the endotracheal tube before its removal. This is particularly helpful in situations where the airway and hemodynamic reflexes associated with extubation are not desired. There may be surgical situations where incisions prevent the application of the face mask after surgery, and sometimes in conditions where you wish to see the vocal cord movements, as may be done after a thyroidectomy. Occasionally, the surgeon wants to see the vocal cord movements before you extubate the trachea. In that condition, the supraglottic device is a big aid. It is known as the Bailey's maneuver, where the supraglottic device can be inserted alongside the endotracheal tube, and the endotracheal tube be removed under vision when the fibroscope is passed through the airway tube of the supraglottic device. The supraglottic devices today also have a role in critical care units and can assist in adult and pediatric bronchoscopies and in particular tracheostomy. The biggest advantage of using the supraglottic devices in conditions like this is that you can continue ventilating the patient and oxygenating the patient through the supraglottic device while manipulations are taking place. This is a picture showing the placement of the device for Bailey's maneuver. The endotracheal tube is in place. The supraglottic device is put while the endotracheal tube is in situ, and a bronchoscope can now be passed through the airway tube of the supraglottic device. The endotracheal tube cuff can be deflated, and the tube can be removed under vision with the fibroscope in place. Now, I recommend that when you are given a device for the exam, many of you will receive during your viva an endotracheal tube. Many of you will also be asked to pick up a supraglottic device. So please don't get flustered. Pick up the device. Take a couple of seconds to examine the device. Even if you've never seen it before in your life, there are certain common parts to the supraglottic devices. If you can identify them and speak about them, 50% of the job will be done. Take the device in your hand, look at it carefully. If it's in a pack, please look at the packing carefully, the name of the device, the size of the device, the weights it is to be used for. Everything is there on that device. So do not get flustered if you've not seen the device before. If you just follow these common steps of identifying the parts, and subsequently, I will tell you the steps of insertion, which are common for all devices. Once you know that system, you will be sorted and will be able to manage in the viva most of the devices. All supraglottic devices will have an airway tube, which will have a proximal and a distal aperture, which will have an inflatable part, which will have an inflation line, and most of the second generation devices will have a drainage tube. Let us discuss few devices one by one. We have to start with the ClassicLMA because it was the prototype which launched this tidal wave of supraglottic devices that we have today. It is no longer recommended that you use this device because much better devices are today available, but you still might have this device lying on the table for you to examine and talk about it. Many times you are given two devices, one a ClassicLMA and one second generation device to compare and contrast. So this is what a ClassicLMA looks like. Every device has certain parts. Please pick up the device and from one end, either the tube end, the patient end, or the machine end, manage to read the device and identify its parts as you go along. So the ClassicLMA has an inflatable cuff. It has aperture bars. It has an airway tubing that is attached to it. At one end of the airway tube is a 15mm connector, which helps you attach the device to either the breathing circuit or to a bag valve assembly. There is an inflation line at the end of which is an inflation valve and an inflation pilot balloon. The biggest disadvantage when you are asked in the exam about a ClassicLMA is that it did not provide any definitive protection against pulmonary aspiration because the oropharyngeal peak pressures of this device are relatively low. Next, after the ClassicLMA came the ProSeal-LMA. I'm describing these devices probably in the areas where probably ProSeal is most commonly used, followed by other devices. So availability and use of these devices is how we are discussing them. Now, this is what a ProSeal looks like. You may be given the two devices to compare and contrast. In that case, as I've said, please identify the parts of the devices. The parts of ProSeal include, besides the connector, an integral pipe block, an airway tube and a drain tube, and introducer strap. How is this device different from a ClassicLMA? There is also an introducer tool available with this device and a deflator. This deflator helps you deflate the cuff and produce a very nice symmetrical leaf-like shape, which aids in introduction of the device. The device has a much larger and deeper bowl without aperture bars, which was seen in the classic LMA. Unlike the classic LMA, which did not have a drainage tube, the Pro Seal has a second drainage tube, which is placed lateral and parallel to the airway tube, and it terminates at the mast tip. There is a posterior cuff, and this posterior cuff pushes the mask and creates a better pharyngeal seal. Along with this posterior cuff and the large bulk of the Pro Seal, a very good pharyngeal seal is created, which means that there is less leak during positive pressure ventilation and less risk of gastric inflation, which means there is less risk of regurgitation and aspiration of those regurgitated contents. There's an integral bite block, which is missing in the CLMA. There is an anterior pocket for an introducer or using your finger during insertion. And there is a wire reinforced tube, which is missing in the classic LMA. Now we will see the insertion technique. The insertion technique is in these slides for a Pro Seal LMA, but these are the steps which are true for every supraglottic device. So whether you are shown a classic LMA, a Pro Seal, Igel, or a Supreme in the exam, if you follow these steps and enumerate them in this order, you will be sorted. So before you insert any device, the first thing to do is some pre-use checks, which include the size selection and inspection of the device. These are followed by pre-use preparation, which includes deflation and inflation of the cuff, mounting, and lubrication. And following that is the insertion, inflation, and verification of the device. We will be discussing each of these steps in detail. So the first important step when you are given the device and asked to talk about it is the size selection. The correct size for each patient is a weight-based selection as per the manufacturer's guideline. It's okay if you don't remember which weight is associated with which size, because most of these devices have written on them which weight category they are meant for. As you can see in this picture, this is a number 3 Pro Seal, which is recommended for patients weighing between 30 to 50 kgs. What to do, you may be asked, if the patient is on the borderline of a weight. For example, if the patient is 30 kgs, a 2.5 or a 3 number device may be inserted in that patient. 2.5 weight range is 20 to 30, and 3 number size weight range is from 30 to 50. So what should you do? If the patient is on the borderline of a weight category, it may be advisable to use a larger size device in that patient because it will provide a better seal. Occasionally, if you end up putting a device where there is inadequate seal or some malposition, a larger size may be opted for before changing the device in that patient. The next step after you have selected the device is the inspection of the device. Always, most of these devices, even if they are single use, must be opened from the packet and inspected. Inspected for patency and integrity of the airway tube, inspect for the connector tube bond, check the apertures, check the markings on the device. Inspect the tube in reused devices to see that it's free of any blockages or loose particles, dust, or secretions within the airway tube. After you have selected the device, inspected it well, you must prepare the device for insertion. To prepare the device for insertion, the steps include deflation of the device to ensure that it maintains a vacuum. Subsequently, inflate the device to see that it maintains the inflation and does not leak. Does it look asymmetrical on inflation? If it does, do not use that device. Once you have inflated the device, you may now slowly deflate it to make a smooth, flat wedge shape, which will help you pass the device behind the tongue. Use the cuff deflator if available, as in the case of a Pro Seal. Now that you have inflated and deflated the device and checked for its patency, mount the device on the mounting tool in the case of a ProSeal. The devices which are preformed do not require this step. Use a lubricant which is water soluble. Lubricate the device just prior to insertion. Do not lubricate well in advance and just leave the device on your trolley. Lubricate it just prior to the insertion of the device. Lubricate the device of the mask, the back of the device thoroughly. Do not spread any lubricant on the anterior surface of the cuff or on the bowl of the mask. For a ProSeal on the posterior surface, and as for a larger device like an Igel, on the sides and back of the cuff, back of the device may be lubricated. Large amount of lubrication may result in cuffing or even airway obstruction if that amount of lubricant is inhaled. After you've prepared the device and lubricated it well, you need to optimize the position of the head and neck and optimize the position of the device in the mouth. The head may be flexed and the head is extended and neck flexed to put the patient in the classic sniffing position for introduction of most devices. To optimize the position of the device in the mouth, ask the assistant to pull the lower jaw downwards, visualize if possible the posterior oral cavity, and ensure that the cuff is not folding over in the oral cavity as it is inserted. Now the steps of insertion. You have selected the device, you have inspected it, you have prepared it, lubricated it well, and these are the steps for any supraglottic second generation device. The device, like a ProSeal, may be held by its mounting tool while keeping the mouth of the patient open. Hold the tool or the device in the dominant hand. Place the tip of the device behind the patient's upper teeth, behind the incisor. Lubricate the device, the hard palate, by moving the device in an up and down motion to spread the lubricant on the hard palate. Once this is done, gently slide the device backwards and downwards with a firm pressure. It's moved along the hard palate, following the palatopharyngeal curve, and ensure while doing this that the tip remains flattened and avoids the tongue. Do not push the device towards the tongue side. Always make sure that the device is pushed along the hard palate. As you move the device, there will be a point where you meet some amount of resistance. When that definitive resistance is met, that is the point where you must stop pushing any further, and the device will rest in its place. The finger insertion technique is not required for any preformed device. The finger insertion technique is described only for the ClassicLMA. This is the bougie guided insertion. The picture shows the presence of a bougie that has been inserted through the drain tube. The bougie is placed into the esophagus and the ProSeal-LMA may be reloaded into place via the drain tube. Various studies have shown that bougie guided insertion may have a first insertion success rate of almost 100%. The next step is cuff inflation. Remember that the cuff has to be inflated before fixation. Make sure that you inflate with the recommended volume of air and do not overinflate the LMA. Do not touch the LMA tube while it is being inflated. As the mask is gently inflated, it will rise slowly out of the hypopharynx. Now, careful inflation is necessary because the intra-volume pressure increases as the cuff volume increases. Now, it has been shown that the pressure exerted on the pharynx by the device is higher than the mucosal capillary perfusion pressure when you fill in the maximum recommended volume of air into the cuff. What that will do is that once the cuff is overinflated with this amount of air, it will increase the pressure exerted on the pharyngeal mucosal structures, leading to mucosal ischemia and subsequent morbidity. So it has been recommended that the cuff be inflated with minimum volume of air which is required to create a seal around it. Inflate to half the maximum recommended volume, but do not go below 1/4 the recommended volume. So after the device has been pushed in place, do not touch the airway tube. gently inflate the cuff with some amount of air, which should be, to start with, minimum amount of air that can provide an effective seal. This is usually half the maximum volume that is recommended. Every device has defined maximum volume of air that can be put for a particular size. For a Pro Seal, a common mnemonic that eases memory of amount of maximum cuff volume of air is, in larger sizes, you take the size number, that is, if it's a 3-size device, -1 from that and multiply by 10. So 3 minus 1 is 2, 2 into 10 is 20. 20 is the maximum cuff volume in that size device. For a size 4, 4 minus 1 is 3, 3 into 10 is 30. That is the maximum amount in the Pro Seal. Occasionally, the examiners may ask you this. This is a small video which shows you the insertion of the patient has been put in the sniffing position. The jaw relaxation is examined before inserting the device. The handle is held by the dominant hand and the device is slid in along the palatopharyngeal curve. The introducer tool is now removed. The cuff is being inflated. Do not touch the device while the cuff is being inflated, and fix the device only after inflation. Do not inflate after the device has been fixed.
Yes, ma'am. Just take a break.
Yes.
So which of the following is a reliable method for confirming placement of a supraglottic airway device? A, feeling a firm stopping point during insertion. No gastric sounds auscultated during bag mask ventilation. Examination by a fiber optic bronchoscope passed through the device, or insertion to the depth indicated on the device. So we have quite a few answers, ma'am.
Okay.
Some people believe it is no gastric sound auscultated during bag mask ventilation.
Okay.
And then examination by a fiber optic pass through the device. A reliable method for confirming placement of a supraglottic device.
Okay.
We have a lot of answers, and mostly C. There's
Okay.
another C, examination by fiber optic pass through the device. Yes.
Okay. So variety is the spice of life. The more variable answers we get, the more fun we have.
Yes, and 3 cheers to everybody who has answered right or wrong.
Yes, absolutely. So the best way to confirm the placement of a device, if you have available, is the use of a fiber optic bronchoscope. If the fiber optic bronchoscope is not available, then probably the use of an ETCO2 can be used. But if available, it is recommended as per literature that the confirmation of the right placement at the right place is through a fiber optic bronchoscope. So 3 cheers to those who have answered C. You must have a form of remuneration to all these who are answering. Do you have that?
Remuneration is applauses and
one chocolate sent through Amazon gift card or something like that, something exciting which
from the teacher.
Absolutely. So you can have a little Paytm delivery to them, or an Amazon gift card which is delivered to the students who answer so well.
From the respective teachers.
Yes, absolutely. Okay, so moving on. After you've placed the device, you've inflated the cuff, it is necessary that you verify both the placement and the function. The most important part of use of a supraglottic device is this series of tests which I'm going to describe now. The first important verification is by visual assessment of the depth of insertion. Then most of these devices have a marking which tells you the appropriate depth of insertion. So relationship of the bite block to the incisors which tell you that the device has reached its appropriate place. If the bite block, as in the case of a Pro Seal, is moving out and the device obviously is inadequately inserted. Observe the front of the neck. A smooth passage of the device, gentle insertion, no obstruction, the bite block at the right place, a slight bulge in the front of the neck are all indications that the device has been well placed, but confirmation is by a fiber optic bronchoscope if available. Put the patient on a ventilator and check for the inspiratory and expiratory flows. You can also do that by manually ventilating the patient, observing the chest movements, look for the ETCO2 graph, look for the compliance of the bag if you're manually ventilating. Keep a check of the tidal volume. The inspired tidal volume must be equal to the expired tidal volume. If that doesn't happen, that means there is some obstruction somewhere. Another test which can be done for its placement is known as the suprasternal notch test or the Brimacombe bounce. A lot of examiners can ask you this in the exam. So the suprasternal notch test, how is it done? It confirms, what does it do? It confirms the location that the tip of the device is in the esophagus behind the cricoid cartilage. Although this is classically defined and described for a ClassicLMA, it can be done with cuffed second generation devices very well. After you've placed the device, you can tap on the suprasternal notch or the cricoid cartilage. While doing this, observe for the movement of a column of lubricant that has been placed at the proximal end of the drain tube. However, you must remember that the drain tube must be patent for this test to be positive. Another test we can do is called the gel displacement test. Again, you can place some amount like 0.5 ml to 1 ml of the water-soluble gel at the proximal end of the drain tube to form a column of about 2 to 3 centimeters. And a minimum movement or a gentle up and down movement of this column of gel while ventilating the patient indicates a normal position. A positive test is when the gel is injected out with force with PPV, with positive pressure ventilation. This will indicate a leak from the drain tube, indicating an improper seal of the device with the hyperfactor. The passage of the gastric tube through the drain tube is a very important indicator that the device has been correctly placed. It verifies the patency of the drain tube, and the posterior folding of the mask has been ruled out. Remember, I've seen many times that the device is put by the person who's managing the airway, and the insertion of the gastric tube is either left to the technician or somebody assisting that person. This is a very important step and gives you valuable information. So if the drain tube cannot be passed down, it indicates trouble. It is a red flag which must be addressed. So it's an important step which should not be relegated to the background to somebody with little experience. After you've done a gel displacement test or you have done the Brimacombe bounce test, you should test for the oropharyngeal leak pressure. This is a very, very important step in the placement of the device and must be done every time with each device. Now, what is the oropharyngeal leak pressure? Many a times when we ask this in the exam, we ask what is the oropharyngeal leak pressure and how do you measure it? Many of the students will talk about the cuff pressure. Remember, oropharyngeal leak pressure is not the cuff pressure. It's not the pressure which is done when you insert some air into the cuff of the device. The oropharyngeal pressure, leak pressure, is the pressure at which gas leaks around the device. It indicates the degree of airway protection. And how do you do it? When you put the device, connected the patient to a closed circuit or to a ventilator, to measure the oropharyngeal leak pressure, turn off the ventilator, close the APL valve of the circuit, put the patient on 100% oxygen with a flow rate of 3 liters per minute. When you do this, the airway pressure in the breathing system will begin to increase. Carefully look at the manometer dial at this time. At a certain point, the airway pressure will increase and attain stability. Once it becomes stable and increases no more, that is the oropharyngeal leak pressure. At this time, occasionally, you may be able to check for audible noise over the patient's mouth, or you may auscultate at the same time just lateral to the thyroid cartilage, to see that if there is any leak and any audible noise. This is a small video to show you how the oropharyngeal leak pressure is done. Every student who uses this must be able to describe the measurement of the oropharyngeal leak pressure in the exam. So you've put the patient on the ventilator, you connect him to switch off the ventilator for a little while, close the APL valve, set the patient on 100% oxygen at 3 liters per minute, and check for the airway pressures. Flow being increased to 3 liters, 100% oxygen. You can see the airway pressure rising. The ventilator has been switched off. The EtCO2 curve has disappeared, and the airway pressures are slowly continuing to rise. The airway pressures have risen and have stabilized at this value, which is shown on the screen. This is the oropharyngeal leak pressure for this device in this patient. Most first generation devices had low air OLPs, only 16 to 20 centimeters of water. And most second generation devices maintain good oropharyngeal leak pressures with seals at pressures of about 25 to 28 centimeters of water. In some places, it's also mentioned from 26 to 31 centimeters of water. Individual second generation devices will have individual oropharyngeal leak pressures. Another test which you must do for confirming the placement and function of the device after you've done all the Brimacom bounce and the gel displacement test and the leak test is checking for the maximum minute volume ventilation. How is this done? You manually hyperventilate the patient for 15 seconds and then extrapolate the total exhaled volume to 1 minute. The basal value is usually 5 to 7 per minute, but a critical value of 12 liters may be kept in mind. The leak pressures are not enough in a patient who has MMV of less than 12 liters per minute. And this is the threshold which has been cited for removal of the ClassicLMA. So always do this maximum minute ventilation test in every patient after insertion of the supraglottic devices. The next step is insertion of a bite block or a roll burst to prevent occlusion of the tube. When should this bite block be inserted, you may be asked. It's done after cuff inflation. Occasionally, if you feel that it may interfere with surgery, it can be done before emergency. It has to be removed, this bite block which has been inserted in the patient's mouth to protect the airway tube must be removed after removal of the device. It can be best located between the back teeth. It prevents damage to the airway tube. LMAs are usually secured after bite block insertion. The method of securing the device is what has been described as maxilla to maxilla and mandible to mandible, as you can see in the picture. Now, what is the role of the drain tube, you may be asked? The examiner might want to know that what all are the advantages of inserting a gastric tube into the drain tube of the device. Obviously, it allows the escape of fluids from the stomach and therefore reduces the risk of gastric insufflation and the risk of subsequent pulmonary aspiration. It also, as we've seen, helps in the optimal placement of the device and helps to determine that it has been placed correctly. Sometimes this drain tube can also be used for monitoring of the patient. Temperature and cardiac monitoring can take place. Now, the next step after you've done this is place the bite block in position, suction if required, and carefully deflate the device before removal. The sterilization of the device is also an important point which may be asked. If the device is a single-use device, obviously no sterilization will take place. These devices needed to be discarded after use. But if it's a device like the ProSeal or a ClassicLMA or something like a blockbuster LMA, sterilization will be required because these devices can be reused. Now, for a ProSeal, the recommended sterilization as per the manufacturer guidelines is 40 sterilization. And steam autoclaving is the best method recommended for sterilizing these devices. Remember that before you sterilize, you must deflate the device and dry it before sending it for autoclaving. Sterilization or autoclaving usually is recommended at a temperature of 135 degrees, following the protocol for the porous load. Post sterilization, the device should be packed only after it has completely cooled. And because a set number of sterilization is allowed, please track the autoclave cycles to know when the device needs to be discarded and can no longer be reused. Certain problems with LMA insertion have been described and may be asked when the device is placed in your hand. These are particularly for the ProSeal, but may be true for any device where the cuff can get folded over. Now, as you can see in these pictures, failure to press the deflated mask up against the hard pallet or inadequate lubrication or deflection can cause the mask tip to fold back on itself. As you can see in the picture, the tip of the mask has folded back on itself. Once the tip of the mask begins to fold over, this can progress, pushing the epiglottis down, causing mechanical obstruction. If the mask is deflated forward, it can again push down the epiglottis, causing obstruction, as you can see in the picture. If the mask is inadequately deflated while insertion, again, it can cause obstruction by penetrating the glottis or pushing down the epiglottis again. Any of these problems can occur with a cuffed device being inserted. The other device, which I would like to discuss in detail, we've discussed a cuffed device like ProSeal. Now we will discuss an uncuffed preformed device such as the Igel, which is very commonly used in most centers. And there is a high chance that this device will be placed on the viva table and you may be asked to answer questions related to it. Now, for the students, Nishant.
Yes, so the Igel has been designed by whom? Any idea? Any of the participants? Yes, Manasa mentions Muhammad Nazir.
Absolutely wonderful.
Very nice.
That's yes. He's a UK-based scientist. Muhammad Nazir is credited with the invention of this revolutionary device called Igel. We are so fond of using it. Now, this is what the Igel looks like. When it is given to you, please pick up the device, look at its size, describe the device in detail from one end to the other end. So this device has a non-inflatable cuff. The most characteristic feature of this device is that the cuff does not need inflation. You may also be asked very frequently, what is the material that the cuff of the LMA Igel is made of? It is made of a thermoelastic elastomer, which is known as styrene, ethylene, butadiene, styrene. 7 sizes of the Igel are available. All of you must know all the sizes available in a particular device which has been placed. So when you pick up the device, you say this is a single-use, second generation supraglottic device. It's called the Igel. It's made of this. It's in this size. And remember, if they ask you what are the sizes available, you should be enumerating all the sizes available for that particular device. For example, Igel is available from size 1 onwards up till size 5. So the size 1, however, does not have a gastric channel. The pharyngeal seal reported with Igel is as good as that of a ProSeal, ranges from 26 to 30 centimeters of water. There is a newer device in the market which is known as Igel O2. You may also be asked about the recent developments which are made in supraglottic devices. This is one of them. This is a device which is available as of now only in adult sizes of 3, 4, and 5. They have a color-coded hook ring. As you can see in the picture, there is a green colored ring at one end of the device. This green colored ring indicates that it's a size 4 device. What is unique about this device is that there is a presence of a supplementary oxygen port. So besides the main airway tube and the gastric channel, there is a supplementary oxygen port, which is for passive oxygen administration. You can put a standard oxygen tubing on this device and deliver oxygen to the patient. The flows of oxygen have been recommended by the manufacturer. And if you set these flows at the recommended level, a desired FiO2 value is achieved. So if you set it at 4 liters, it will deliver an FiO2 of 0.35, at 6 liters, 0.45, and at 8 liters flow, 0.5 FiO2 can be delivered. Another cuffless mask which is also available in the market, I thought I'll briefly cover this since we've covered Igel, is the BASCA mask. Again, as I said, many people may not have seen a BASCA mask before and may find it in their hands on the table. Please do not get flustered. Look at the device carefully, define its parts and the uses. You will be able to get through most of the viva if you follow the points which I have already outlined before. What is peculiar about the BASCA mask, again, is that it's a cuffless mask with a self-sealing membranous pore. It has an insertion tab, an integrated bite block and an airway tube, a dual drainage system, and a sump area, which allows for secretions to be collected. A very detailed description of the device is outside the scope of this talk, and interested students may look at the literature which is available online related to the BASCA mask. Question, Nishant?
Yes, ma'am. So the use of a supraglottic airway device with a self-inflating or pre-inflated cuff may reduce the chances of which of the following complications? Compression of the carotid arteries, displacement of the soft palate, vagal nerve stimulation, or gastric decompression. Supraglottic device with a self-inflating
or pre-inflated cuff, something like an Igel or a BASCA.
Yes. So we have responses and slightly mixed response again, ma'am. Dr. Sonu believes it is displacement of the soft palate.
Okay.
Dr. Mansa believes that it is gastric decompression.
Okay.
Dr. Priyal believes it could be vagal nerve stimulation. So it is a mixed bag this time. We have a lot of responses.
It's a mixed bag, and as far as what you've told me, we've not seen the correct answer. The correct answer for this question is compression of the carotid arteries. There is evidence in literature, it's been reported that large pre-inflated devices may increase the chances of compression of carotid arteries. So A is the correct answer for this question. That round goes to me.
Yeah, we did not have an A in this.
Yeah, we did not have an A in this. Okay, now we've discussed the ProSeal in detail, we've discussed the Igel in detail, and another mask, the device without a preformed cuff like the BASCA. Let us now briefly discuss the AMBU family. The AMBU family has many devices which may be shown to you, you may be using it, you may be very familiar with it. These include both second generation and first generation devices. The two pictures on the top are AMBU Aura 1s and AMBU Aura 40. These are first generation devices as they do not have a gastric channel and are no longer very popular or recommended. The devices which you can see in the third and fourth picture on the lower half of the screen are AMBU Aura Gain and AMBU Aura I. We'll be discussing these devices in the subsequent few slides. Okay, so one more question for the brilliant students watching.
Yeah, so what is the largest size of endotracheal tube that can be introduced through the AMBU Aura Gain? People believe it is 8.
Most of them have said 8.
Yes, most of them have said yes. Praveen mentions the 7, Dr. Praveen.
Okay.
But yeah, Dr. Parmeet, Dr. Praveen, Dr. Nisha, they believe it is 8.
Okay. Okay. So the correct answer to this is yes, it is 8. Why it that is, we'll just come to see that. As you can see in this slide, last size of the mask is 6. Ambu Aura has size 6 available, through which you can introduce an 8-number tube. Okay. Now, majority of these devices have an integrated gastric channel. They are preformed devices. They have integrated bite blocks. What is interesting about these devices is they have navigation marks in the airway tube for guiding your flexible scope. And as I've mentioned, size 6 is also available in these devices. Another very popular device, which may be available to you, shown to you in the Viva, is an LMA Supreme. LMA Supreme is again a disposable device. It's made of PVC. It is a preformed device. It has a reinforced cuff which prevents folding of the mask. It has a built-in bite block. The peculiar features which are present in this device is the presence of a fixation tab. And this airway device has an elliptical airway tube. It forms an effective first seal and a second seal with the upper esophageal sphincter. So because of the fact that it's very rigid, it's preformed, and it has an elliptical airway tube, the AP diameter of the airway tube is much less than in other devices. So the beauty of this device is that it can be introduced in conditions where the mouth opening is relatively reduced. Now, one of the contraindications cited for insertion of a supraglottic device is reduced mouth opening. But that is also a relative contraindication. Up to 1.2 to 1.5 centimeter mouth opening may be enough to introduce a supraglottic device such as Supreme. So out of all the devices, probably this is one device which can be inserted with relatively less mouth opening of 1.2 centimeters. Now, interestingly, the fixation tab tells you where to fix the device. 1 centimeter of gap, as per the literature, should be maintained between the patient's upper lip and the fixation tab. If the tab is pressing down on the lips or is very close to it, it means that your device is too small. And if the tab is more than 2.5 centimeters away from the upper lip after fixation, the device is too big. So some examiners may also ask you this relationship of the fixation tab to the size of the device and the correct placement. As we had asked earlier, this is one device which is not good as a conduit for endotracheal intubation. If you remember, this was one of the MCQs which has just been done. Why it's not a good conduit for intubation is because the drain tube runs through the middle of the airway tube, dividing it into 2 parts. So there is very little space available for maneuvering of the endotracheal tube through the airway tube of the Supreme. It's not a good tube for intubation. These are the sizes available. If you can see in this chart, the maximum cuff volume is relatively higher for a Supreme as compared to other supraglottic devices. It has a very large inflatable cuff. The volumes are slightly higher as compared to other devices of the same size. Another new device in the market is what is known as LMA Guardian. Some examiners may ask the students as to recent developments in supraglottic devices. One of them I've already mentioned is the oxygen port in the Igel, and another device which has newer modification available in the market is the LMA Guardian. What is specific about this device is that it has a pilot balloon valve with a pressure logo. So pressure monitoring can take place with the help of this pilot balloon valve. You needn't have, although pressure monitoring of intracuff pressure is recommended for all devices, you must have a monitor to monitor the intracuff pressures. But in this device, This pilot balloon valve with the pressure logo can be used to monitor the device visually. Once you inflate the device, it will tell you whether it is overinflated, it is appropriate, or it is underinflated. Two other new devices which may be asked or very popular these days are LMA protector and the LMA protector cuff pilot. What is different about these devices is these devices are meant for endotracheal intubation. They allow endotracheal intubation with a very, very high success rate. Look at this device. This is a silicone-made device, currently available in sizes 3, 4, and 5. It is anatomically shaped. Again, like the Supreme, it is elliptical in cross-section. The unique feature of this device is that it has two separate drain channels. One is a male suction port and the other is the female drainage port through which you can insert a nasogastric tube or a Ryle's tube. It also has a built-in pipe lock, and the device may or may not be available with the cuff pilot. The routine LMA protector is not available with the cuff pilot, but the LMA protector cuff pilot is available with this cuff device, which I have already described in the previous slide. One of the very popular devices which is available in the market today is known as the LMA blockbuster, the laryngeal mask airway blockbuster. Again, like the LMA protector, the LMA blockbuster is designed to facilitate endotracheal intubation. Most of these devices, it is recommended that the endotracheal intubation be fiber optic guided. However, the website and associated literature with blockbuster indicates that endotracheal intubation can be made successful even or can be attempted blindly through this device. This is what the literature says, but it is recommended that all endotracheal intubations, if possible, be fiber optic guided. What enhances the success of intubation through this device is that the airway tube is angled at an angle of 90 degrees. It is relatively short, and the angle of emergence of the endotracheal tube through this device is at an angle of 30 degrees. This is unlike the intubating LMA, where the tube emerges at an angle of 40 degrees. Through this, the tube emerges at an angle of 30 degrees, which increases the success rate, and the tube very easily passes into the glottic opening when it exists from the airway tube of the LMA. Many of the previous devices which were used for endotracheal intubation had large air or longer airway tubes. If you've seen the protector and if you've seen the LMA blockbuster, the airway stem is much shorter, which allows more successful endotracheal intubation. If the stem is long, you pass the airway tube through the endotracheal tube through it, it tends to get lost. In this, the stem is smaller. Also, this device is available, which is meant to push the tube in and then remove the tube over this device, which is the exchange guide. Another good feature of the device is the presence of the Parker Flexi tip tube. This special tube is the Parker Flex tip tube, which decreases the damage to the structures as the tube passes from the LMA into the glottic opening. So this device may be placed and you may be asked to define the features of that device. You may be asked why it is successful in allowing intubations. You may also be asked subsequently which are the other devices which allow intubation and why this device is more successful. So we've answered most of these questions by now. This is a chart which tells you that through the blockbuster number 5 and 8 number tube can be negotiated. Now this is because the lumen of the airway tube in the LMA blockbuster is much larger and can allow an 8 number tube to be passed. So all those devices which are specifically meant for intubation. For example, the AMBU or a GAIN. GAIN stands for gastric inlet and intubation. GA is gastric access and IN is intubation. And AMBU or a I is specifically meant for intubation. All these devices have large airway tubes, which endotracheal tubes of large internal diameters can be pushed, and they have stems which are much smaller to allow increased success of endotracheal intubation so that the endotracheal tube doesn't get lost in the airway tube of the supraglottic device. So a few more questions for the PGs if they're still awake.
I'm sure they must be awake, ma'am. It's such an interesting talk. Question: inserted by holding the device like a soup spoon. Which device is inserted by holding the device like a soup spoon? Is it the Igel, LMA Supreme, ClassicLMA, or ProSeal-LMA? Like a soup spoon. We have mainly D's and A.
Okay, so more D's, more A's.
More D's to begin with, yeah.
Okay, the answer to this question is Igel.
Igel, yeah.
A. Igel is traditionally being defined as you hold the device like a soup spoon. You hold it within your 2 index fingers and your thumb, which is placed in the middle of the airway tube. This way of holding the device has been defined as a soup spoon hold. Okay, next question.
The next question is, putting the patient in sniffing position helps the correct placement of most supraglottic airway devices except blockbuster LMA, Basca mask, ProSeal-LMA, or the combi tube. Putting the patient in the sniffing position.
So which of these devices do not require a sniffing position? That means which of these devices can only be put in the neutral head position?
People believe it is combi tube, and it's between combi tube and blockbuster.
Okay. No, the blockbuster has a much higher success rate if you put the patient in the sniffing position, as is the Basca mask or the PLMA. The combi tube, however, requires the neutral position to be inserted.
Yes.
Okay, so briefly, we've described, see, it is not possible in this short talk to have a description of all the devices. I've intentionally kept the devices such as the LTS or the combi tube away from this discussion. We've focused on other supraglottic devices, post first and second generation. We've described the way of inserting the device, the specific features, how to test for the device, what is the leak pressure, and all the important parts have been discussed. What I'm going to discuss now is also probably generic and holds true for any supraglottic device that is shown to you. Now, what is the contraindication for using a supraglottic device? We've done the indications before. We've said that it can be used for routine anesthesia, it can be used for difficult intubation, it can be used as an extubation guide, it can be used to guide the endotracheal tube in. We've done all that. It can be used in resuscitation for cardiac arrest, it can be used in the ICU. But is there any contraindication for using this? Yes. Patients who are at definitive risk of gastric aspiration. Remember, we had an MCQ where we said that this patient, there were patients who were non-fasted, like the pregnant patient who was probably consuming fluid in the labor room. There were patients who had definitive history of gastroesophageal reflux disease or who have a diagnosed hiatus hernia. These are the patients who have a high risk of aspiration after regurgitation. In these, it is contraindicated. Patients with decreased lung compliance, you may not be able to achieve good ventilation. You may have very high airway pressures, which surpass the seal pressures in patients who have decreased lung compliance, and it's relatively contraindicated. Because the tip of most devices will sit on the beginning of the esophagus or the opening of the esophagus, patients who have esophageal varices, esophageal trauma, history of upper GI surgery, history of upper GI bleed, may not be suitable candidates in which a supraglottic device is placed. Patients who have reduced mouth opening less than 1.5 centimeters, probably who have distorted anatomy where you're not sure of the placement of the device. If there is surgery involving the upper airway, severe maxillofacial trauma, and morbidly obese patients. But before I finish, I would like to emphasize that majority of these indications are not absolute. Today, we have a wide variety of patients who are obese, who undergo surgery with a supraglottic device in situ because they have traditionally what is known as a difficult airway, and use of supraglottic device may aid intubation in these patients. Today, surgery involving the upper airway, such as tonsillectomies, may also be done with the use of a supraglottic device. Sometimes the distorted airway anatomy is what is responsible for making the airway difficult, and the supraglottic device may be a boon in these patients because it allows smooth oxygenation. So majority of these contraindications are not absolute, and each patient must be evaluated on its individual basis before you place the device in that patient. Lastly, what are the complications of the device? Regurgitation and aspiration of gastric contents has been reported. Misplacement of the mask and airway obstruction, malpositioning, dislodgement, inadequate sealing, which subsequently leads to gastric inflation and aspiration. Some amount of upper airway trauma like tongue congestion and NEPA has been reported with larger device. Of course, cough and laryngospasm if you remove the device in a right plane, and sometimes vocal cord palsy and nerve injuries have been reported with the use of larger devices. To summarize, recent advances in supraglottic devices have significantly enhanced the clinical utility of these devices. They play a very important role not only in routine management of anesthesia by replacing the endotracheal tube in a large majority of indicated patients, but they have a very, very definitive role in the management of difficult airway, where you may encounter situations such as difficult mask ventilation, difficult laryngoscopy, or difficult intubation. It can be used as a conduit successfully for intubation as well as bronchoscopy. It can be used by paramedics with adequate training to secure the airway in out-of-hospital arrests and field situations. A knowledge about indications and contraindications and features of the device is very essential for their appropriate use. Correct insertion technique must be followed to ensure optimal positioning. Concerns such as pulmonary aspiration of gastric contents still remain, which means that careful patient selection and device selection is mandatory on a case-to-case basis, and checks for function and position should be done every time the device is placed. I finish by this very beautiful quote which says that if you're willing to learn, if you are not willing to learn, nobody can help you. But if you are determined to learn, nobody can stop you. So knowledge really empowers you. And my thanks to all the students who've been patiently listening to this lengthy talk for the past 1 hour. I hope I've managed to cover most parts which are exam oriented. See, it cannot be an exhaustive talk on supraglottic devices, but majority of what will be asked from you in exam has been covered in the talk. And I hope this talk was useful to most of the students who have been listening in.
Thank you, ma'am. And that was such a nice talk. It is one of the shorter 1 hours that we have had. It was not a lengthy 1 hour at all. And you can just take a little break. It was a very nice lecture with all the videos and all the recent advances. Most of the new supraglottic devices you have covered. And I'm sure it will be very useful for all the postgraduates. If you're ready, if you allow, ma'am, then we might have,
Yes.
some questions in the chat box.
Yes, please.
Dr. Monica might, could you just ask Madam, what are the questions that have been asked in the chat box?
Yeah, actually, when the lecture was going on, since then people have been asking some questions. So our first question was from Dr. Shashikala, how to do cuff leak pressure test. I think she has got the answer through the lecture.
Yes.
Yeah, and Dr. Nisha, maximum airway pressure till which supraglottic airway device can be used?
I mentioned in the lecture the maximum cuff pressure. They want to know the cuff pressure or leak pressures. The maximum cuff pressure cuff device is 60 centimeters of water, but oropharyngeal leak pressure maximum as quoted in literature is 40. Majority of the devices you should be able to determine once you put the device in, you should be able to determine what is the leak pressure for that particular device in that particular patient, depending on the anatomy of that patient.
I think the name is not mentioned, but someone is asking the role of LMA in TURP surgery.
Yes, LMA. Today, LMA is used in a wide variety of patients and wide variety of surgeries, whether it's prone position, whether it is obese patients, pediatric patients. Your device is safe once you've placed it well and done all the checks. That is what protects you. That is what ensures safety. No surgery is completely safe. No device is completely unsafe. So once you've put the device, please do the tests for placement and functioning, do the Brimacom bounce, place the gastric tube, do the maximum minute ventilation test, and do the tests for the oropharyngeal leak pressure. If these tests are, if you pass these tests, you can use the device in any surgery. So particular surgeries are not indication or contraindications for a device. Your tests are.
Some of the people are confused between this thing, oropharyngeal leak pressure and ceiling pressure.
Okay.
Many of them are asking this.
Yes. There was another short question here which talks about the duration of surgery for use of LMA. I wish to emphasize that duration of surgery is no longer an indication for use or not use of a supraglottic device. I've heard this being said many times over by students, that, or even for practitioners who use, practitioners means all of us who are using LMA, that ये लंबी surgery है, ये 3 घंटे चलेगी, इसमें हम supraglottic device नहीं डाल सकते. That is not true. Supraglottic device is a definitive airway device. Please, at the risk of repeating myself, supraglottic airway device is a definitive airway device. If it passes all your tests, the duration of surgery is not an indication or contraindication for use of a particular device. Okay. Now, somebody wants to know what is the difference between oropharyngeal leak pressure. See, the oropharyngeal leak pressure, there are 2 pressures. One is the esophageal pressure. That is the pressure at which the leak from the esophagus will take place. The second pressure is the oropharyngeal leak pressure. This is the airway pressure. If that pressure is reached, there will be the leak which occurs will allow the contents to enter the airway tube, will allow the contents to enter the patient's trachea. So when you measure the airway pressure by the test which I have described, at certain point, it reaches a certain maximum airway pressure. That maximum pressure is known as the leak pressure, which means that beyond that point, if the airway pressure rises, there will be no protection against aspiration. That is what is the oropharyngeal leak pressure.
I think someone is asking about the Bailey's maneuver in detail.
Okay. Interestingly, the Bailey's maneuver, I wish I could show, actually the time constraint, I had a whole lot of videos, but I was not very sure I could exceed the time and keep showing them to you. The Bailey's maneuver is a very, very effective method of using a supraglottic device at the time of emergence and extubation. How it's done is that you have tracheal tube in situ. For example, after thyroidectomy, you wish to see the movement of the vocal cords. Now, it really beats me how people have been doing it all these years, saying laryngoscope डाल दो और cords की movement देख लो. आप please मुझे बताइए जिस patient का anesthesia terminate हो गया, जिसका muscle relaxation reverse हो गया, वो कैसे allow करेगा one laryngoscope which is thrust into the mouth. So the way out is to do what is known as the Bailey's maneuver, which means that you take a supraglottic device, for example, an Igel, you insert the supraglottic device behind the endotracheal tube while the tube is still in situ and the patient is anesthetized. You can deepen the anesthesia and reverse the neuromuscular blockade, put in the supraglottic device behind the endotracheal tube, then insert a fibroscope through the supraglottic device. Once you enter and see, you will be able to see the vocal cords and you will be able to see the endotracheal tube going into the vocal cords from the bowl of the supraglottic device that you have inserted, which lies behind the endotracheal tube. Now, under vision, while you're seeing the vocal cords, you can deflate the endotracheal tube cuff and remove the tube under vision while seeing the movements of the vocal cord. This is known as the Bailey's test. Occasionally, this modification is also used if you do not want, see, an extubation is an extremely, what should I say, traumatic part of the airway management. There is a severe rise in blood pressure and tachycardia can take place. Straining of sutures can take place. All this can be avoided when you have this maneuver where you put in a supraglottic device, allow the patient's extubation to take place, and then gently awaken the patient on the supraglottic device. So that minimizes this stress of extubation. So these are the modifications of the supraglottic devices.
There are one or two more questions, ma'am. Dr.
Yes.
Nikita is asking, is lateral position required during surgery and an absolute contraindication?
No,
for
no.
supraglottic?
Lateral position is not a contraindication for the devices which have a good seal. Your seal should be good. Then you can put these patients in the lateral position. There are many studies available if you just care to search, where oropharyngeal beak pressures have been checked in the lateral position with various devices. These studies have been done for pediatric patients as well as for adult patients and have shown that largely if your device is working well, then you can use it in the lateral position. It is not a contraindication to the use of a supraglottic device. What is the incidence of regurgitation and aspiration? I think somebody is asking. I believe you wish to know the regurgitation and aspiration incidence for supraglottic devices. It is comparable to endotracheal tubes. Statistically, most studies show that it is comparable, but a few places it is also less than that of an endotracheal tube. So what I can definitively say is that it is not more than what is reported for an endotracheal tube.
I guess that's all, ma'am. Anyone, how can LMA be used in place of face mask? Yeah, I
Okay,
think
wonderful. Yes, that was a picture which I showed in my presentation. This is one of my own patients where we have this whole set of pictures which I wish I could have shared with you maybe another time. There was a large growth on the mass on the patient's face. We've had these series of hemangiomas. We have a surgeon who does a lot of hemangiomas since I come from a predominantly pediatric hospital. So what happens is it was very difficult to place the mask on the patient's face because of the large growth. So once you induce anesthesia, make sure oxygenation takes place. That means you can have a catheter placed in the nose where large flows, high flows of oxygen are being delivered. Once that is taking place, you induce anesthesia. Once the IV anesthesia is induced, after induction, you can directly introduce, you don't have to do bag mask ventilation. Directly introduce the supraglottic device and connect your oxygen, connect your circuit and oxygenate the patient through the supraglottic device.
is prone position a contraindication, ma'am?
No, prone position is not a contraindication. Studies are available, literature is available, we do use it. You must be very, very sure about your device, about your indication, and must do all the tests very, very diligently before you use this device in the prone position. It is not for the initially new initiated. You must be very well versed with the device, with your patient before using it in the prone position. But per se, prone position is not a contraindication for the device.
I think, what is Chandy's maneuver? Dr.
Yes.
S.
Yes, a Chandy's maneuver is typically described for the ProSeal, sir, which has been described by Chandy Verghese. And I've had the pleasure of meeting Dr. Chandy Verghese in the Airway conferences. He's a wonderful person. And this maneuver, which is described, is to allow better placement of the ProSeal. So there is a Chandy 1 and there is a Chandy 2. The Chandy 1 allows you to manipulate the device to optimize ventilation. And the Chandis 2 maneuver allows you to optimize the device for intubation in a proceed.
Over to you, Nishant sir. I think the questions are over.
Anything else, Nishant? I think we've.
I unmute everybody to interact directly with you. I'm unmuting everybody so that they can directly interact with you.
Yes, yes.
Now everybody is muted, but you can unmute yourself. And Dr. Krishna Kumar has raised hand. Please go ahead, Dr. Krishna Kumar.
Yes, yes, Dr. Krishna Kumar.
So, LMA gastric use or endoscopy.
Yes, yes. LMA gastro is being used. I personally don't have much experience with LMA gastro per se. We don't have that in our center. But LMA gastro is a wonderful device which allows you to do upper GI endoscopy while maintaining oxygenation and ventilation through the supraglottic device. And one of the very beautiful things about the supraglottic devices is that while you are attempting these procedures, while you're attempting bronchoscopy, while you're attempting endoscopy, upper GI, or you're attempting intubation through these devices, it allows you to continue oxygenation and ventilation. You can have a connector with the device, continue ventilating the patient, and with the device in situ, you can continue to do your endoscopy. It's a wonderful device. I haven't used it. I have used it. I don't use it very frequently because it's not available in our center, unfortunately. But it has separate outlet for the endoscope to go in. So you can place the device, allow the patient to be ventilated, oxygenated, and anesthetized if required. And while you are doing that, simultaneously, there is a port which allows you to introduce the upper GI endoscope through the mask. It's a beautiful device with a very high success rate. Any other questions, please?
In MRI center, safer LMA.
Okay, okay. Igel is one device which can be used for MRI. It is being said that its device is safe. Any device which basically doesn't have a metallic part. So in our center where we are doing MRIs, we are using an Igel. It's very safe. It's available in all pediatric sizes. The placement is very simple. The leak pressures are very good. It maintains a beautiful seal. And we are using an Igel for our MRI center.
Thank you, madam.
Any other? Okay. Somebody wants to know what are the supraglottic device options for pediatric patients. Do we have options for neonates? Yes, these days options for neonates are available. Majority of the second generation supraglottic devices have sizes for neonates. So Igel number 1 can be used for neonates less than 5 kgs. Ambu Aura Gain, Ambu Aura I have a huge range of sizes and pediatric sizes are available. We are currently using the Blockbuster LMA also, which is available in the pediatric sizes and can be used for neonates. So all these devices which have sizes 1 available, like the Igel or the Ambu Aura Gain or the Ambu Aura I or the Blockbuster, can be used in pediatric patients. In my practice, I am majorly a pediatric anesthesiologist. In my practice, in many cases, we've replaced the use of an endotracheal tube with the LMA in pediatric patients, particularly for outpatient surgery. Okay.
Dr. Mohan has raised hand.
Yes, sir, please.
That madam, endoscope, when you pass gastroscope through LMA,
Yes,
Does
sir.
it have a separate channel for ventilation?
Yes, sir. Yes, sir. The channel for ventilation,
Okay.
the channel for the scope is separate, sir.
Okay, okay, thanks.
Yes, sir.
Okay.
Actually, I had not covered all these aspects because I tried to tailor the talk, particularly for
Yeah.
graduates, and I kept it very exam-centric so that once they listen to this talk, they don't fluster. Anytime they get a supraglottic device in the exam and are able to answer the questions which most of the examiners end up asking related to a supraglottic device. I wish I get another chance and we can cover its more aspects about the use of supraglottic devices. It's a very, very, very vital and
It's a very
absolutely, and the
it's a very big topic.
very big topics are, and the use of supraglottic devices has revolutionized the airway management. You know, the safety of managing the airway has really gone up, and all those adrenaline pumping moments which we normally get when we are encountering a difficult airway is taken care of because one, we have a supraglottic device on our trolley, and second, the availability of a video laryngoscope. These two things have really made life absolutely simple and safe for management of the airway, whether it's a pediatric.
Difficult airways. Yeah.
Absolutely, sir. Absolutely.
Even in newborn, it can be used.
Yes, sir. We are using, not in all newborns, because, you know, there are newborns who are preterm, there are newborns with birth weight, they have associated congenital anomalies. You know, there is a whole wide range. So I cannot.
That is also available.
Yes, yes. You cannot have a blanket statement for neonates, but in very small select cases, if you're very careful, see, vigilance needs to go to a separate level, absolutely the next level when you're using these devices for neonates. The margin of error is very low. So but yes, devices are available in the market which cater to neonates. Let me put it like that.
Okay, thank you,
madam.
Thank you, sir.
Hello, madam.
Yes, sir.
What complications you come across during your practice, madam? Is there any complications?
Sorry, sir, I didn't get that. Sorry, ma'am.
Complications. Is there
complications? Okay, okay. Yes, ma'am. Complications in cesareans or in any patients with supraglottic devices, you mean?
Yes, yes.
Yes, yes, of course, complications occur. The more you use the device, the more complications you see. If you use it thousands of times, you're bound to see complications. I've seen aspiration and regurgitation. Early days of practice, we were not very familiar with the devices at that time. I've seen aspiration, I've seen misplacements, I've seen folding of the device, I've seen trauma to the tongue, I've seen trauma to the epiglottis, I've seen ventilation failure. Yes, we've seen these complications, but the incidence of these complications is very, very low. It's not very high. Extremely safe devices to use, and but I strongly recommend, like every time I place the device, I always test for the OLP, and all my PGs do it. The moment they place the device, they use the suprasternal notch test, they use the bubble test, then they do the OLP test, and then they do the maximum ventilation test for every device that is placed under my supervision. So once you do that, the safety of your device increases.
Thank you.
Yes, but the incidence of complications is very, very low.
Yes, very nice.
Thank you.
Dr. Anita.
Good evening, ma'am.
Yes, good evening.
Ma'am, good evening. Ma'am, given a choice in a prone patient, would you like to use supraglottic device or other faculty?
Depends on the patient. See, there is a lot of things. Depends on the patient, depends on the surgery, depends on the device I have available at that time. You know, if it's probably a thin patient who's undergoing a smaller procedure, I will not hesitate from using. A very obese patient, maybe I would think twice. So it is a very individual decision. But I always say, if you are even a little hesitant, if you're not sure about your device, if you're not sure about the placement, if you're not sure about the complications, do not use the device. Use it in prone position only when you're very sure you have used it. use it in peacetime first to then use it in wartime. So similarly, use it in the prone position only after you're very well versed with using the device in the supine position, then in the lateral position, and lastly in the prone position. You must
Thank you, ma'am. Thank you.
available. You must have a good assistant available. You must be extremely vigilant. You must have a good monitor to see all the airway pressures at that time. Only when you meet all these requirements should you attempt to use the device in the prone position.
Thank you, ma'am.
What to do if the supraglottic device is displaced intraoperatively, like in laparoscopic surgeries? It tends to.
I hope that never happens, but you know, once the device is misplaced, it depends on what you're talking about misplacement, but you may have to remove the device and put it again. You may have to replace the device. You may have to recheck the device after replacing it. You know, occasionally the cuff pressures are not good. You may not have inflated the cuff well. During positioning, it may have got disturbed. So the best thing to do is to remove the device and reinsert it and redo all your checks.
I think that's all, ma'am, for today. Thank you for such a descriptive talk. We
Thank
enjoyed
you.
thoroughly.
Thank you so much.
Mohan Pathak has also raised hand.
What to Naveen, sir?
No, no, I asked, I finished, sir, finished.
Okay.
Sorry, sir. I thought you had raised hand again.
Okay.
It has been nice interaction and excellent deliberations over the last almost 1 hour and 45 minutes. Though, to be honest, I was prepared for 7 p.m. because when Dr. Ranju is speaking and there are...
Had you told me this, Dr. Naveen, a little earlier, I would have expanded the scope of the talk and included a lot more, which I didn't do because I was scared I would, you know, exceed the time. So I kept a little time, question answers, and limited the talk. But there's always the next time. So
Now we all fully understand that if we start talking about supraglottic devices,
it's a never-ending topic.
maybe a full day CME also.
Yes.
So, but it was honestly, I really enjoyed sitting through the class, and I'm very sure all others also had a very fruitful interactions with you and must have been very, very useful for the exam going postgraduates. And we all from ISA online PG classes wish good luck to all our students who are sitting in their theory exams or practical exams in the month of May and June. With this, we formally conclude this session by formally thanking once again.
Thank you so much.
Dr. Ranju.
Thank you for this wonderful opportunity. My best wishes to all the students and my big thanks to ISA for giving me this opportunity. Thank you so much. It was a pleasure.
See you all next Monday, same time with another interesting class. Thank you.
Thank you, Dr. Naveen. Thank you, Nisha.